staging system. I don't have, yeah, we can show this.
Alright. This is does anybody know what this is? Stage 1, 2, 3. Huh?
Can you stand up?
I don't want to. It's a stage 1. Yeah. So this is going to be, it's only to the epidermis. Your skin's always going to be intact. And when you're touching it, it's not going to blanch. Non-blanchable. That's stage 1. It's usually located over your bony prominences. You got your heels, your hips, coccyx.
Yeah, here in Tisha, let's see, I'm thinking of patients that are high risk for developing stage 1 pressure ulcers. Will be patients that are coming after surgery, their mobility is limited. Specifically knee replacements, hip replacements, the leg that was had surgery, most likely that's the heel that we're going to have more concern. They will be able to readjust the other leg in bed, but that affected leg, definitely you want to check for any pressure ulcers. And a pressure ulcer develops, you know, if you stay more than 2 hours in one position, you can reposition, you're really starting the process of developing pressure ulcers. It can happen overnight. So it's important to just put a pillow and relieve the pressure. Patients with stroke, patients with pelvic fracture also, anybody that is, you know, is limited mobility, and, you know, people that are really weak for any kind of infections that they can reposition themselves, then they would be the persons with high risk of ulcers.
This stage 2 is going to be a partial thickness. One thing about stage 2 is it's painful, and partial. 3 Ps. It's going to give you a stage 2. Patient has all 3 of those. I documented as a stage 2. And another thing with documenting on stages with wounds, pressure ulcers, if you have a stage 4 pressure ulcer, you're never going to be able to reverse it to a stage 3. It is always going to be a stage 4. It's going to be a healed stage 4. You can't reverse that.
We're talking about the way we document. I mean, of course, the wound is going to fill up and you know, it's going to be superficial. But in your documentation, it's always going to be a stage 4 healing with a good healing, you know.
The 2 or 3 is not like that. The 2 or 3 is not like that.
It is
Yeah,
with any
yeah.
stage.
Okay.
You can go from a stage 1 to a stage 2, but you can't go back. Stage 3, you've got partial thickness, some subcutaneous tissue. And then you got some fat. I tried to have them shrink this down a little bit so you could see some fatty tissue in there. This is stage 4. You've got bone exposed. Anytime your bone is exposed, that's stage 4. Muscle.
That looks like a tendon. With the stage 4, the stage 3, it goes to the subcutaneous tissue, but with the stage 4, you can see muscle, you can see bone, you can see ligaments, you can see nails. Yeah, pretty much. One thing about stage 2, if you want to go back to stage 2. Skin tears, anything wounds made for tape or any superficial wounds, we don't consider those stage 2. I want to emphasize here that this classification is for pressure ulcers only. So when the other ulcers that you find like skin tears or any other kind of ulcers, venous ulcers, arterial ulcers, you are not going to talk about stages, stage 1, 2, 3, and 4. We're talking about the way we document are they partial thickness or full thickness wounds. So if it's clean and red, you were going to say that it's partial. If it's deeper, if it has necrotic tissue, slug tissue, look dirty, you can't tell how deep they are. Most likely those are full thickness wounds. This is pressure ulcer.
That you can stage not stage, but categorize skin tears if you need to.
Yes.
I can print up information on that. I was just showing here, you've got some slough. I'd say it looks like snot in the wound. A lot of people don't know what slough looks like. It's a dead tissue,
But we do know.
necrotic tissue.
I think the difference between the slot and the scar is one is more hydrated than the other one. And probably that one in the top, if you leave it open and to air, most likely it's going to become like the one in the bottom. It's going to get dry and hard.
This is a deep tissue injury. And this one is just, they've got pressure in an area and it's over a bony prominence and it's just purple and maroon in color, but it's not open yet. Could be a blood-filled blister also.
Yeah, the difference, if you see there is not an open wound, okay, there is no open, so you will say, if it's not open, probably you will say stage 1, yes, you know there is some pressure there, but that's the latest in the classification. This is the big change that happened, because you know it's not a stage 1 because it's already dark, and the tissue, you expect that it's going to be a deeper damage. You cannot classify it as a stage 2 or 3 because it's not open. So you know how deep the tissue, the damage is. So that's the name is deep tissue injury.
Okay. And also on this here, you can't really see the wound bed because you've got the necrotic tissues here. So you would document that as unstageable. If you can't see the wound bed, it is unstageable. I just want to show you, this is what maceration looks like. So if your wound's been a little too wet, start to get moist around the edges, and that's going to impair your healing process there. Your necrotic tissue and slough.
So when we find a wound like this, what do? We measure. Part of the assessment is to see how much drainage it has. We want to definitely remove the eschar, remove the dead tissue, because the dead tissue, if we leave it there, is going to produce, is going to increase the bioburden, is going to increase the risk for infection and bacteria growth and microorganisms going there into the wound. It's going to progress to getting the tissue keep dying. So we want to clean those wounds, and we want to promote the healing process. If you see in the top, on the top bone, it has already granulation tissue growing there.
This is kind of beefy red. It's kind of what they call granulation tissue. It's bumpy.
For the one in the bottom, you can find heels with a black scar, and if it's dry, if you don't see any redness around, if there isn't, just a black scar dry, most likely we consider that wound stable. We are not going to debride, especially if it's a patient with diabetes, because most likely patient with diabetes or impaired circulation, most likely those wounds are going to get bigger and they never going to heal. They don't have the enough blood supply for the tissue to heal. And so those patients, we're going to leave them alone. We're going to put protection and we're going to decrease the pressure or offloading the heel. And that's pretty much the treatment on those black scar when there is no drainage, there is no redness, and they are stable. If there is something like this, the scar is just in one small area, and you see redness around, probably have a lot of, drainage. Most likely that those wounds we're going to, again, offload the heel. We're going to remove the scar, and we're going to put either through char debridement, or we're gonna use enzymatic debridement ointments to keep it moist and to eventually go through the dressing changes, remove that eschar. And we have, what we've been using is the wound vac. This has been a really good treatment for pressure ulcers. I have, what it does is provides negative pressure in the wound. So we put a black foam on the wound. We cover with the drape, and if we seal the wound completely, then we attach by the we attach it with this, and we attach it to the machine, and it will create a negative pressure. And what it does is promotes the granulation, it controls all the drainage, it brings the circulation to the wound, it promotes the fibroblast activity to create granulation tissue grow in the wound. And it helps to remove all the debris. So, Tisha, you want to be my guinea pig, and I'll show you guys how this works. Okay. So let's say that you have a wound here. Anybody has some scissors?
Just pretend.
Okay, let's pretend. We cut this to the right size. We hold the wound really well here.
There is a certain order to take this stuff off.
Yeah, they
too.
have numbers in this dressing. Number 2 here. This is really big. Let's say it's completely sealed. Make a hole with the scissors. Put this in the wound. And we attach this to the wound vac, and then it provides the suction to the wound. We treated a lady here this year. She is, I think the case study is in the paperwork. I don't remember what it was. Pressure ulcer. It's an 84-year-old female. She came because she had a sacral ulcer, and what happened was she was living with her husband at home, and she fell and broke her shoulder, and then she went to a nursing home for rehab. I don't know what happened in the nursing home, but then one day she called her family and she said, I don't like the way they're treating me here, and told her family to take her out of the nursing home. They found a pressure ulcer. Apparently they didn't know about it, and she came to the hospital with it. Apparently after she fell, then the mobility decreased and she spent more time laying in bed. She wasn't moving as good as she was doing before. When she was living at home, she was walking the home distances with a roller walker. So, and she was, independent, walking in the house with a roller walker. Then when she came to see us, it was because she had, hypertension, diabetes, heart surgery, dementia, and the management was she was cleared up for surgery. She had char debridement, and then 3 days after the char debridement, we put her in a wound vac.